let us start with our presentation on how to sleep better in the neuroendocrine treatment and survivorship. And that is actually very, very broad, which is exactly how we want it, right? So yes, it's about neuroendocrine, but it's probably more than that. And we have the delight to present Ben Brewer. Again, he's a doctor of psychology, right, yeah, doctor of psychology. My sister-in-law is a PsyD as well. Director of Clinical Psychology and Counseling here in the Division of Hematology at the University of Colorado. He's an associate professor of medicine here, and he is a clinical health psychologist with expertise in providing evidence-based psychological intervention and assessment to oncology patients. He is an expert in the clinical treatment of insomnia, right, which is what you guys are suffering from, in the context of cancer and cancer survivorship, and has a research and clinical program in the use of telehealth, love it, telehealth, and mobile health applications to provide augmented therapy enhancement for oncology patients and their caregivers. And he is a full member of the University of Colorado Cancer Center. So, ladies and gentlemen, please, let's introduce Dr. Brewer. Awesome. Thanks, buddy. Thank you. I appreciate it.
Well, good morning. You guys can all call me Ben, and I'm going to be talking to you about some basic sleep biology because I find it totally interesting, and I'm very much a sleep nerd. And so I'd love to teach you a little bit about that. Then we're going to talk about some circadian stuff, some biology that comes every 24 hours. And then we're going to talk about some behavioral treatments for sleep before I hand off to Erin Bowerly, who's going to tell you a little bit more about some other components that will help you sleep better. So everyone always asks, how much sleep should I be getting? And the answer is actually a little different for each person. This is a very helpful slide in that it can help you see what the sort of averages are for most people. Most people, like I would say 80% of people, kind of live within those dark blue bars. And you can see for young adults, adults, and older adults, that's 7 to 9 hours or 7 to 8 hours. You also notice that we need less and less sleep as we get older and older. And that's a really interesting thing. Often my older patients will come in and say, I'm only sleeping 6 hours. And I'll say, okay, well, are you feeling bad? And they'll say, no, but I used to sleep 7. And I'll say, okay, maybe that's okay. Right? And we don't need to stress about it, which could make you not sleep well. 6 hours might be okay. Now, if you're used to sleeping 8 hours and all of a sudden you're only sleeping 6, and you're exhausted during the day, your brain's not working well, your emotions are all over the place, then we want to do something about it. Does that make sense? So sleep is a neurobiologic imperative. Anything with a brain sleeps. They've found that even jellyfish now have a sleep mode. Some animals, like birds and dolphins, have figured out how to sleep one brain hemisphere at a time, so they can literally sleep with the other eye open. And so it's evolutionarily kept around, even when it seems to put organisms at risk, right? Like if you're sleeping, you're vulnerable to being attacked, or people could sneak up on you, or you could get eaten by a lion in the middle of the savannah in Africa. And it wouldn't have stuck around in such a durable and profound way if it wasn't absolutely needed for human health. And I find this really interesting. Like it's a non-negotiable thing. Healthy human sleep is comprised of 2 general states. And when they started studying sleep, they noticed that there was some phases where people's eyes moved back and forth really fast when they were asleep, almost like they were awake and looking around. And this is where we have our dreams, most of our dreams. And then there's this other phase, which is called non-REM sleep, non-rapid eye movement sleep. And that is defined by slower and more organized waves on what's called polysomnography. Polysomnography is a big fancy. If you go to a sleep lab, they will wire you up to all these things that look at your brain waves. You've probably seen people with these wires coming out of their head. It looks really impressive. And then they have little sensors to see what your eyes are doing. They have breathing and heart rate sensors. And what we find is that when people are in non-REM sleep, there's 3 kinds of it, which I'll explain on the next slide. They have low muscle tone. Their body's relaxed. They have low respiration rate. Their breathing slows down. Their heart rate slows down. And there's a whole bunch going on in the brain. This is not just a rest mode. This is a very fancy cleaning program for the brain. that helps do many, many, many things. In REM sleep, your muscles should be paralyzed. There's this disorder where this doesn't happen and people act out their dreams, and it's rough on their bed partners or sometimes their furniture. It's quite a thing. But it's supposed to be paralyzed and your brain is very active. So this is what a typical night looks like. You can see sort of in the top left there, this is the electrical activity from all those wires that I was talking about. And when we're awake, it's sort of this gentle chatter. Our brain is processing what's going on in the world. It's taking input from the senses. Then as we start to fall asleep, we fall into stage 1 sleep, which is also called theta. It's just the name for the phenomenon on the EEG machine. And theta, it looks very much like you're meditating or very relaxed. But if you wake people up in this stage, they almost always they're not quite sure they were asleep, right? It's that part where your mind feels wandery when you're drifting off. Stage 2 sleep is a little deeper, and you'll notice that the waves are getting bigger as we get into deeper and deeper sleep, right? And I find that fascinating, like something else takes over. In stage 2 sleep, this is about 50% of our sleep across our lifetime is stage 2 sleep. And you can see some little bigger blips in there. Those have names like K complexes and sleep spindles. I will not go into all those today, but they have specific functions. The more we get into this program, the more we can see that it's really complicated and really interesting. And it's one of these things where the rabbit hole just keeps going. And I find that to be cool. We've now combined stage 3 and 4, and we just call them deep sleep. Deep sleep is the good stuff, right, for adults. When we sleep deeply, we wake up feeling refreshed. If you sleep deprive people, their brain automatically does the deep sleep first. And you can see on this graph of the sleep stages across an 8-hour night that the deep sleep is prioritized in the first 3 hours of the night. The REM sleep tends to become more and more toward morning. And so the brain really, really finds that helpful, and if people are getting deep sleep, they can at least function at a basic level. So I think it's fun to look. Yeah. Okay. Thanks. So when humans don't sleep, we become a mess very quickly. And I put the slide in just for fun because it's interesting. I think it's actually very hard not to sleep. And this is total insomnia where people don't sleep at all. So humans develop emotional instability, impulsivity, hallucinations, paranoia, major cognitive attention problems, and increasing trouble staying awake. They start having micro sleeps. They nod off while driving, flying a plane, or driving, in the case of the Exxon Valdez, an oil tanker. And you start to nod off. And then most people have really significant problems after 48 hours, meaning sleep is so important that we really need it. Current world record for staying awake is 11 days. If you're feeling ambitious, I highly recommend that you don't try this. Guinness took this out of the Book of World Records after this high school kid in San Diego, Randy Gardner, decided to stay awake for 11 days. He had his buddies drive him around in a car to stay awake. And this really famous sleep psychologist or sleep doctor, I don't know if he was a psychologist, came down from Stanford to San Diego to watch this happen and documented the whole thing. Randy's still around today. He's a full adult now, and he doesn't sleep very well. And they actually think there's a correlation between people that have been profoundly sleep deprived, people in wars, people in other settings like that, that they end up developing insomnia. Unfortunately, in the bad old days, we did animal research where we discovered that sleep-deprived rats, this is total sleep deprivation, die in 11 to 32 days without sleep. There's a human analog to this, which is terrifying and thankfully incredibly rare. But it's the case of fatal familial insomnia. This is a very rare prion disease, which is a protein folding problem in the brain that prevents entry into deep sleep, although these folks do have REM sleep. And unfortunately, they have dementia and then death around 18 months. This does run in families, so if you don't know anyone who died of it, you're probably okay. It's incredibly rare. The consequences of chronic partial sleep restriction, as Dr. Liu was mentioning, are much more common to our normal experience and my experience. That if you sleep restrict people to 4 and 6 hours a night, and people in the study really got like 4 or 5 hours, it was pretty significant sleep restriction. For 14 days in a row, they have the same cognitive performance problems as if they stayed up 1 to 2 days, but the difference is that they don't realize it. So these people are actually quite dangerous behind the wheel. They're actually not very good at stuff. Their emotional regulation is off. We know that living your life like this is really bad for you, as Dr. Liu referenced. So it drives obesity, heart disease, insulin resistance, type 2 diabetes, colorectal cancer, and immune dysregulation, right? Over or under responses to things the immune system's supposed to react to. It also makes people bad at things socially and emotionally. So sleep problems drive all kinds of mental and medical concerns, as I've been referencing. Chronic pain is very related to sleep. We all know that pain keeps you awake. What most people don't know is that not sleeping generates pain. Even if you sleep-deprived people that don't have pain, they will develop pain. Treating sleep problems is actually a very effective, we call it a transdiagnostic therapy. And that means that if somebody has anxiety or depression or panic, or struggles with substance use, that treating their sleep, if they also have insomnia, improves all of those other things at once. And it's very, very powerful. And the reason why we do this a lot, I do this in my practice, I see patients with all kinds of cancer-related mental health problems. And I find if they come to me with all these problems and we treat the sleep first, then the other things automatically get halfway better. And then I take the next biggest problem on the list and then we address that. So I hope that makes sense. This really affects the immune system and even our response to vaccines, recovery from illness, all those things. So NETs, as Dr. Liu mentioned, are very associated with insomnia. In fact, cancer in general is very associated with insomnia. 60% of neuroendocrine tumor patients have trouble sleeping. About a third of these at any time meet criteria for insomnia. The definition of insomnia is that it's a bigger and more severe problem than just having a little trouble sleeping. And I'll go over that in just a minute. But it's caused by many factors, including stress, nighttime discomfort, diarrhea, these flushing symptoms, things like this at night. And then these drive circadian rhythm changes associated with neuroendocrine tumor related symptoms and treatment. Now, there's also lots of evidence that people that just have cancer of any kind have sleep problems, and they're not all related to biological causes. They're related, many of them, to emotional causes and other things like that. But in the case of carcinoid nets, some of these release hormones. They overproduce different hormones that directly impact the sleep and circadian system. And I'll talk about those on the next slide a little bit more. And they disrupt the sleep-wake cycle. They make it hard for the brain to keep time like it normally does accurately. And other nets can impact blood sugar and may also impact sleep in that pathway. So here's a quick little table of the common sort of highest risk for biologically driven sleep problems. Now, lots of people have insomnia that's not driven by these in the neuroendocrine tumor space. Particularly small intestine nets that release serotonin. They actually process a lot of and attract a lot of tryptophan, so they deplete it, and that actually in the brain makes it harder for the brain to make serotonin, which is related to melatonin, which you've all probably heard of, which helps turn on the sleep system at night. And so that's like a classic case where something that the tumor outputs can really impact the availability of melatonin in the brain. There's other ones of these. The lung bronchial cancers are also kind of high risk for this because they tend to release histamine, or more rarely they release things that trigger a cortisol release in your body, which is a stress hormone that can help sort of mess with the circadian cycle, particularly at night if that's happening. It's not supposed to be there so much at night. So some general tips related to carcinoid syndrome. You want to talk to your physician. Only about 30% of NET patients have a tumor that's putting off these hormones that will affect sleep. But if you have insomnia and you have this kind of a neuroendocrine tumor, it would be really worth reaching out directly to your physician and talking about anything that chemically or medically could be done. And it's very specific for each person. We don't yet have good research. As Dr. Liu mentioned, there's a lot that we can still study in neuroendocrine tumors and sleep. But So we don't totally have proof that addressing the hormonal issues will resolve sleep problems, but there's plenty of things in medicine we do without having a study of 100 people to guide us, and your physician can help you figure those things out. Insomnia driven by carcinoid syndrome or anything else can be very effectively treated using traditional approaches to insomnia treatment that we actually understand very well. And it also can be treated, particularly in the case of folks with cancer, with circadian alignment. And I'm going to talk about circadian alignment first, and then some of the behavioral approaches that we use to treat insomnia. So when I say circadian, what we're really talking about is the day-night cycle on the planet Earth. And for the last 2.5 billion years, life has been evolving on this planet. And organisms have figured out ways of taking advantage of the fact that every single day it gets bright and warm, and then it gets dark and cold. And we have a sleep mode. And if all organisms sort of go against our circadian rhythms at their own peril. It will make you ill to not be in a normal day-night cycle. And we've proven this again and again. People that work shifts, people that are up all night, that have really dysregulated systems are much more likely to develop cancer. They're much more likely to have mental health problems. They're much more likely to be feeling like they're jet lagged all the time because they're essentially jet lagged all the time. And that's not a good feeling. So we have all these clocks that keep track of time in our brain, and I find this totally interesting. They time out a little bit longer than a 24-hour day in all of our systems. We have a master clock in the brain. This is the suprachiasmatic nucleus. It's about 20,000 neurons that take signals from the eyes that are about if it's light or not. Basically, that's the main clock setter. We also have many subsystem clocks for our metabolism, for other organs, for our digestion, that are timed off of that clock. That's why when you have jet lag, everything feels all screwed up. Almost every cell in the body has a clock. There's a little molecular clock in a tiny fashion ticking out a 24-hour day in all of the trillions of cells that we have in our body. We have about 36 trillion cells, and almost all of them have clocks built in. It's kind of amazing, I think. So we have ways of setting these clocks, and these have been termed, because the research was done in Germany originally, as time givers. And in German, that's Zeitgebers. German likes to run words together in kind of a fun way. So time givers, the most powerful one is bright white light. But there are many, many of these that have been identified. The timing of eating, the timing of social activity, all of those things are Zeitgebers, time givers. They set our clock. Humans, if we take them down in caves where there's no temperature change, there's no light, and we let them select their own schedule, turn on their own lights, eat when they want to, go to bed when they want to, they just run later and later all the time. We can feel this pull in our normal life. We all kind of want to stay up later, and we want to get up later every day. And we need time cues to fight that. People who live outside, they tend to get up with the birds at about 5 a.m., right? And then the light comes up and doesn't let you sleep anymore. That's a very healthy way. That's the way we evolved to live. Some people run a little bit longer or a shorter clock, and we call these larks or owls. They're people that are early birds or they stay up late. And that's genetic. It's on a gene, and it's heritable. So you see whole families where everybody gets up early or everybody stays up late. I want to give you clinically actionable things to help your circadian rhythm be aligned, because you will feel better, you will sleep much better, and many other things in your body's system will run better. This actually reduces inflammation, and it's been shown, all of these individually have been shown to reduce cancer-related fatigue, which is always, it's a little different than sleep, but it's a big complaint of folks. So light exposure in the morning makes sense. We wake up, the brain looks for the sky. It looks for bright blue or white light. You need 30 minutes minimum dose in the first 2 hours after awakening. The metabolic system needs to rest at night. And so I tell my patients to not eat in the 3 hours before bed. Have dinner, then stop eating, then don't eat again until the morning. And that's just a really simple rule you can follow. There are more complex versions of this, but this is a nice simple one. Have a sleep-wake schedule. Particularly if you can only do one thing for circadian alignment, get out of bed at about the same time every day. And really get out of bed Open your blinds, get some light exposure. That's really important. And then do exercise. It can be walking. It can be simple things. It doesn't have to be a marathon. Colorado has all these people that are super, exercisey. But you can really just go for a walk. And if it's a short walk, if that's what you've got, that's great. You want to not do that right before bed is the only caveat. So insomnia, as I mentioned, is a sleep disturbance that leads to dissatisfaction with sleep quality or quantity. It has to cause impairment. It has to bother you in different environments. And it has to go on, we usually say, you have trouble with this problem at least 3 nights per week for at least 3 months. Now, if you have a new NET diagnosis or you get admitted to the hospital and you've been having trouble sleeping for 2 weeks, I say we treat it, right? We don't need to wait around for 3 months for you to prove that you have some definition somebody made up of insomnia. We can start working on that right away. And in many cases, we can prevent it from becoming a chronic problem. We know very clearly that insomnia evolves in what are called the 3 Ps. These are all words that start with P. So you're a predisposed person. These are your buddies on a transatlantic flight that are awake with you and everyone else is resting, and asleep. You're the ones that are awake. We tend to be worriers. I'm one of these people. We tend to be light sleepers. So you're a predisposed person to it, maybe. Now, in the cancer population, there's a lot of people who aren't predisposed that still get insomnia. And then there's something that happens. These are fairly normal, a precipitating event. So maybe it's a new cancer diagnosis, a hospital admission. Maybe it's a medical cause, relationship troubles, stress. Could be anything, right? That triggers a few nights of bad sleep. And in normal folks that don't have insomnia, they start sleeping again after that. Maybe they even rebound a little bit. But in people that have insomnia, something weird happens. They have these perpetuating factors that show up. So they start to worry about their sleep. They have weird behaviors around sleep. And then there's these conditioned responses that prevent sleep. And we can target these with good, simple therapy. This is not tell me about your mother therapy, although I do that kind of therapy too. But this is very simple, effective behavioral therapy. I'm wondering if anybody can recognize this person from a picture, and I doubt it. I'll give you a hint. He's from the 1800s. He is not the Santa Claus on Miracle on 34th Street. It's not who this is. He was a dog lover, and he was Russian, and he won the Nobel Prize. Does anybody have a guess? Very good. You guys are better than some of my graduate students. This is great. All right. So yes, Ivan Pavlov discovered classical conditioning by training dogs. He gave the dogs meat and measured their drool. And when dogs get meat, they drool. And he rang a bell at the same time. And then he discovered he could take away the meat and ring the bell. And he had a fun party trick in that the dogs still drooled. And what that was a different kind of learning that he discovered. It's reflexive. It's not conscious. The dogs weren't thinking that they were going to drool with the bell, but it was a different kind of learning. And it turns out, I'm telling you about Russians and dogs because insomnia works the same way. It is maintained in large part by classical conditioning. Also, there's operant conditioning discovered by B.F. Skinner. Basically, the idea is that being awake, alert, or frustrated, or in pain, or vigilant in bed pairs this with the bed, just like the dog got the bell paired with the meat and the drooling. Does that make sense? And so the brain goes, oh, it's like unsafe to sleep here. Let's not do that. And in our long history of evolution, people who lie down anywhere it was unsafe got eaten. And so their genes didn't get passed on. And so we have people that were actually, the prevalence of insomnia in general society is more than 12% of people. It's a very common problem. You can see all these drug companies marketing a lot of pills because it's a huge market of people that want to sleep better. So these circuits are triggered very easily in the brain. And in people with insomnia, they set up, and we have to do something actively to break that conditioning and restore the bed as a place of sleep. So how do we do this? So the American College of Physicians recommends that all adult patients receive cognitive behavioral therapy for insomnia as the initial treatment for chronic insomnia. That's not a pill, it's a therapy, right? This is one of the most effective treatments in all of behavioral medicine is actually the treatment for insomnia, and it's called cognitive behavioral therapy for insomnia. It's also effective in oncology patients. Josie Savard, University of Ontario, reviewed these 8 studies with a combined N of 752 people in the study, and she showed good effect sizes for self-reported insomnia severity. It got better. If you're a stats nerd, that is a Cohen's d of 0.77. It's a very good effect, meaning these people started sleeping a lot better after a few weeks of this therapy. It's durable after treatment for 6 months or a year, and there's very few side effects. Ironically, one of the initial side effects is tiredness, and you'll see why in just a minute. There's even brief protocols. I don't do a whole course of CBTI with my patients. It takes too long. I like to give them quick things that work well, and I'm going to teach you the quick things that I do for people right now, and then Aaron is going to tell you a little bit more about some of the other ones that also really are effective. These are the 5 components that are in this therapy. The first one is called stimulus control. I don't know why we have to use these big fancy names for everything in my field. I think psychologists are kind of insecure that we're not like medical, and so we have to make it sound really good. And I think stimulus control confuses all of my patients, but the idea is really simple. You only sleep in bed and you don't sleep anywhere else. I will tell you more about that in 1 second. The other one is sleep restriction or compression. I like sleep compression because it's a little more relaxed. But that's just limiting the time in bed that is available for sleep. A lot of my patients are spending like 10, 12 hours in bed trying to sleep more, and they're only getting like 4 hours of sleep. And it's terrible. So you're spending all this time where the conditioning can map onto the bed, right? Where you're awake, you're alert, you're in pain, you're uncomfortable. If you take normal people off the street that don't have insomnia and you make them spend 12 hours in bed, they will develop insomnia because of Pavlov, right? That will all condition and map onto the bed. Then there's cognitive therapy that Aaron's going to talk about. Relaxation techniques we all know or have heard of, but practicing them at the right time and doing them right is really great. Aaron's also going to talk about that. And then I'm going to mention sleep hygiene education, which is actually the least effective of these components. Stimulus control is, as I said, one of the best ways to reduce the pairing of the bed with vigilance, stress, pain, alertness. It basically means if you're having a bad night, you want to get out of bed and not allow all of that stuff to pair with the one place where you're trying to sleep. To do this, what I want to tell you is to make a nest. And this is not part of the formal therapy for CBTI, but it's something I came up with because I think it's the only way to actually do this comfortably. I don't know about you guys, but in the middle of the night, I don't necessarily want to go to a cold, dark, different part of my house and sit around when I can't sleep. It just doesn't feel like the right thing to do. So what I've been telling my patients is to make a nest. So pick a spot tonight before you go to bed where if you have a bad night, if you've been up for hours and your body temperature's rising and you're getting stressed or you're in pain or you're just feeling vigilant or alert or you're worried about something, and decide that if you've been doing that more than a half an hour or you don't feel like you're going to fall asleep, you feel like you're ramping up, go somewhere else, take some deep breaths, do some relaxation, but never sleep in this other spot. So lay it out before bed, put a blanket there. You can put some herbal tea there if you want. Give up on sleeping for a little while. Go there, try to relax. And if you get sleepy, go back to bed. We're giving up a little bit of time in bed in the service of sleeping better for basically the rest of your life. Does that make sense? This is very much a hard work kind of therapy, right? It's hard to do this at night, but it works. To do the next part, you might want to keep track a little bit of how you're sleeping. And just noting roughly, you can do this in your head if you're kind of a good rememberer of how much you slept and what time you woke up, but it's nice to be able to track it. We have provided for all of you a simple sleep tracking form. It does have instructions on it that in all of your handouts that you can look, it's a piece of paper, and you can color in the boxes where you're asleep that will help you track this. But I also use an app called CBTI Coach that's totally free and was developed by the Veterans Administration to track your sleep. This will also help you do CBTI on your own if you want, but you could certainly contact people like me or like Seth to help you get coaching around this, because it's hard to do things with just an app. So what I use this with my patients for, and you can take a picture of this, I think you'll have access to my slides also. It's available on the Apple Store and Google Play. It should be totally free. Nobody's making any money off this. It was built by the government for just to help people. And I have no relationship with anybody that designed it, but it's a good free app. And it tracks your sleep, and then it makes a nice graph of concepts that are really helpful. One of those concepts is called sleep efficiency, and this is simply how much sleep time you have over how much time you spend in bed, right? So if you're spending, let's say, 8 hours in bed, but you're only sleeping 6, I won't make you do math to figure out that percentage, it's 75%. And what we want is for sleep efficiency to be at or above 85%, roughly, right? If you're 80 and you feel fine, great, no worries. Again, if you don't have insomnia, you don't need sleep therapy. You don't have to worry about your sleep efficiency. But if you have insomnia, this is a way to improve it, right? At or above 85%. And so using that app or tracking, you can calculate that roughly for yourself if you want. Sleep compression is the single most effective component, I think. If I had 10 minutes to teach somebody how to sleep better, I would do this, and they had insomnia. So you will not get less sleep, but only less time in bed is the key thing to remember. So let's say you're only sleeping 4 hours a night. What we would do is restrict your total time in bed. Instead of like 8 hours, you would actually just get about 4.5 or 5 hours in bed. Now, patients look at me like I'm crazy. They're like, you mean I have to go to bed at midnight and get up at 4:30? And I'm like, yeah, for 2 weeks. And then what we do, that 2 weeks clears out the conditioning. Their brain magically sort of loses that distress. And then when we expand them back out in chunks, they actually start sleeping way better. It's almost like magic. They often come in at 1 week and tell me that it's terrible and it's not working. And I've learned over 15 years of doing this with people to tell them to stick to their guns and keep doing it. And invariably they come back the next week or the third week sometimes, and they are delighted that they're sleeping better. And then we can expand it out. So here's a visual. If you like pictures, here is a way to look at that. So this person was spending like from 9 p.m. to 9 a.m. in bed. And in the compressed version, we just cut out the extra time in bed. And then, this was a normal 8-hour sleeper, let's say. So over the coming weeks, after a few weeks of reset, we let them expand back out. Does that make sense? So I think we can all do this. I do this when I get a run of insomnia, where I'm, screwed up for some reason. I have too much work, something's going on, my children are waking me up, and it works pretty quickly. Sometimes you don't have to wait 2 weeks either. Sleep hygiene is actually not effective without the other components. If we just do this in cancer patients, it doesn't really work. That's not true if you have one big problem. I had a lady who came to me for insomnia, and her cat was in bed clawing at her at random times during the night. And I was like, you don't have insomnia, you have a cat problem. So we use behavioral methodology to train the cat, and we put the cat outside her room, actually, and her insomnia went away. So it's important. You'll have access to these. I think these are kind of common sense, and they're also kind of on the internet. This is what the internet thinks sleep therapy is, but it's actually the least effective component. I will say that having a wind down period, 30 to 60 minutes before bed, is really helpful. So many people are wondering about pills. Again, there's massive marketing budgets people are spending trying to convince you that a pill is the right way to sleep better. And it turns out that they do work a little bit. The average improvement of sleep onset for Ambien, Zolpidem, is about 20 minutes for people when they take it. And that's, great that we have a drug that does that. But if you have insomnia and you're only sleeping 4 hours a night, which is who they studied for these studies, 20 minutes is not like a victory, right? CBTI works to restore pretty much your normal sleep. And so this is really different. These pills also increase N2 sleep, which is that middle sleep, but we get about 50% of already. But it decreases the good stuff, the deep sleep. And we want deep sleep. We really need it to clear out junk in our brain. People who get more deep sleep have less dementia as they get older. They feel better. Their emotions are better. So we don't really want to do that. And it sort of makes you do that. It also decreases REM and N1 sleep. And then there's a lot of side effects, right? In people that have cancer and people that have been in the hospital, these side effects are even worse. In people that are older, as many cancer patients are, these side effects are also worse. So I have trained my team not to use Ambien at all in my population. Very rarely, I send people to a sleep psychiatrist, and we can do that, right? And if they really need it for some particular sleep problem, it's fine. There's a lot of people that take Ambien every day, and it is not FDA approved for that. The FDA actually just walked back the minimum dosing for women, they cut the dose in half, the start dose, because they were having so many problems. There's also problems with sleep eating, sleep driving, sleep walking. It causes these problems, and they're non-significant. They're extremely significant problems. There's other drugs that work, but only a little. Belsamra is the newest one. It's an orexin antagonist. It's a cool new way for sleep biology people to get excited that we can affect sleep. However, it costs $10 for each 20 milligram pill, per pill, not per prescription. $20 a pill, or $10 a pill. And then the average sleep improvement was only 6 minutes in this study. Now, some people really do respond to this. It's not that if you're on it, it's bad. If it's working, that's great. But again, this is not a victory of science over sleep. Diphenhydramine is Benadryl. It's the active ingredient in Tylenol PM and Advil PM. It works okay for a few nights, and then the body really quickly forms a defense to it, and it quickly stops working. You do not want to live your life also on Benadryl. It is not good for you to be on something like this unless your doctor tells you that you need to be taking it. It's an anticholinergic drug. Even though it's over the counter, it's not great long-term to live this way. And then trazodone is actually the most popular prescribed drug for cancer-focused sleep psychiatrists. And I work with one at the Cleveland Clinic and another one at Dana-Farber who use trazodone. I recommend my team prescribe trazodone. I don't prescribe, I'm a psychologist. So it works, and it actually increases deep sleep a little bit, which is good. Some people find it makes them too groggy. And it's not habit forming, which is nice. But again, it's actually better to do this without trazodone. And trazodone hasn't been studied a whole lot, but it doesn't produce wild improvements in sleep either. So, and then there are all these concerns about short-acting hypnotics. Those are things like benzodiazepines. So, including drugs like lorazepam or Ativan, Xanax, alprazolam is the other name for that one, and then some of these other drugs that I mentioned, Ambien and Lunesta. These things are GABA-A agonists, and they all they get there different ways, but they all stimulate this one sort of neurotransmitter in the body, and that may be problematic. So these were never recommended for chronic use, as I said. There's all the concerns that I mentioned about falls, cognitive issues, dementia, and then we see these elevated cancer and mortality risks with a demonstrated dose-response curve. When these studies first came out, I sort of ignored them as being poorly done, but now there's a bunch of them, and they're kind of concerning that taking drugs like this for a long period of time seems to be correlated with people dying of a lot of different causes and also developing dementia. And so that's a little frightening to me. So all to say, you shouldn't be living your life on these sleep drugs. The best way to treat them is with really behavioral and cognitive behavioral therapy. So now we're going to change gears. You are welcome to email me at this email address if you have questions. We're also going to have a panel in a little bit, and I'm very happy to be part of this group answering questions about sleep and sleep biology.